welcome everybody to the Psilocybin Assisted Therapy Association, also known as PADA. Our training on pharmacology of psilocybin presented by Ann Chatterton, RN, is a very good friend of mine and colleague, and an amazing presenter and wealth of information who specializes in psychedelics and is very familiar with the industry and particularly how it pertains to, to drug-drug interactions and just helping the community at large with this. Hosting today will be myself and Lisa Ritter. We're LPC. We are the co-founders of the Psilocybin Assisted Therapy Association. We will be moderating the chat content on the side. We'll both be responding if needed. And feel free to address us individually if you have questions that you don't want to ask the general public. And with that, I will pass it along to Ann. Thank you very much.
Thank you so much, Jason and Lisa. If you haven't checked out PADA, please do. We share the same vision of educating other professionals and the public on the uses of psilocybin in a safe manner. This is my first time ever doing a Zoom call for so many people, and it's kind of disconcerting to not be able to see people. It feels like I'm talking to myself. So bear with me on that. I'd also like to thank a couple of other people, Mary Nielsen, who's my former boss at Clinical Cognitive Facilitator Training, for getting me a beautiful start and introducing me to Jason and so many other wonderful people. I'd also like to mention one of my favorite businesses in Portland, High Desert Spores. I'm plugging them. They are on 50th off of Fremont. If you need supplies, that's a great place to go. And that being said, let's go ahead and jump on in. This is the pharmacology of psilocybin, drug-drug interactions and dosing, what you need to know. Okay, and there we go. This is my contact information. I was asked if I would consider starting a consulting firm, and so I did. The website, however, is not up and running yet. I hope to have that up by next week, but it's called Psychedelic Solutions, and it's www.psychedelicsolutions.co. There is not a .com. Or you can email me at psychedelicsolutionspdx@gmail.com. I am in the process as well of getting my own psilocybin facilitator license. I just left a position training the facilitators, and now I'm going to be a facilitator myself. And I have been working with this medicine since about, I'm going to say 2017, 2018. So there's a little thing there. I guess we're in the placebo group, which I just thought was funny. And why learn pharmacology? So learning about the pharmacology of psilocybin can help us to understand its potential therapeutic effects, explore innovative treatments for psychiatric disorders, educate ourselves and our clients, and work towards reducing the stigma of psychedelic medicines. So some years ago, pre-pandemic, I worked as a home health nurse, and I had a patient that was being followed by my boss, but she was on vacation, so I saw him for the first time. And he was a long-distance truck driver who unfortunately had had an accident and then became an amputee. He's lost his leg, so then he lost his job. And as I do on all intakes, I asked him how was his pain, what was he taking for pain? And he and his wife looked worriedly at each other, and they were kind of clammed up at first, but finally shared with me that they were using cannabis to help with the phantom pain. And he had said that he was reluctant to share that with me because his doctor had threatened to fire him if he continued to use cannabis. And of course, in our state, in Oregon, it is legal to use cannabis recreationally. And I hear so many stories like that. And I also do know, having been a nurse for 3 decades, that a lot of us just aren't trained on cannabis medicine and psychedelic medicine. And so I went back to school and got a master's degree in medical cannabis science and therapeutics because I believe that these medicines actually help people. I'm not anti-pharmaceutical, and I'm not all pro-drug. There's pros and cons on both sides, but I really feel like this does help. Okay. So to start, I don't know what everybody's baseline knowledge is of pharmacology. So I'm going to start with just a really basic intro to pharmacology. Psilocybin and pharmacology. So of the roughly 30,000 documented species of mushrooms, about 200 are known or suspected to be psychoactive. Psilocybin is a naturally occurring psychoactive compound that is found in several species of mushrooms, including the Psilocybe genus. Its unique molecular structure accounts for its diverse effects on the brain. Psilocybin is the main psychoactive principle of hallucinogenic mushrooms. After ingestion, psilocybin is converted into the pharmacologically active form called psilocin. Psilocin itself is also present in the mushroom, but in smaller amounts. Baeocystin, norbaeocystin, and aerogenicin are also present depending on the species, or may be present depending on the species. Baeocystin and norbaeocystin are chemically similar to psilocybin structurally. They're psilocybin with 1 and 2 methyl groups removed, respectively. We don't know the full extent of these 5 alkaloids yet, but I'd have to hazard a guess that just like cannabis, we're looking at that entourage effect when we have the whole plant, or the whole fruit in this case. Psilocybin is both an alkaloid and a tryptamine. The definition of an alkaloid is it's a nitrogenous organic plant compound of plant origin. Tryptamines act primarily as hallucinogens, and they mediate specific serotonin receptor activities. Some other tryptamine compounds are DMT, LSD, ibogaine, LSD, and 5-MeO-DMT. So what is pharmacology? Well, pharmacology is the branch of medicine which addresses the uses, effects, and modes of action of drugs. And there's 2 branches of pharmacology. There's pharmacodynamics and the pharmacokinetics. With pharmacodynamics, this is the action of the drug on the body. It's the relationship between the intensity of the drug's effect in relation to its concentration within the body. It explains the mechanism of action, shorthand MOA, and how the drug binds with a receptor. So in other words, what does the drug do to the body? When you take an aspirin, what does it do to the body? In contrast, pharmacokinetics is the action of the body on the drug. It addresses the way that the body handles the drug. It's how quickly or slowly a drug's metabolized or excreted, and illustrates how the concentration of the drug changes as it moves throughout the body. So what does the body do to the drug? And this is what we're going to be focused on for the purposes of this lecture. So I want you to remember the acronym ADME, okay? Pharmacokinetics can also be explained as a way that drugs enter and leave the body. ADME is shorthand for the absorption, distribution, metabolism, and elimination. And from now on, I promise you, now that you know this lecture, you're going to start thinking about every time you take a vitamin or any type of pill, how this is working in your body. So the first part of ADME is the absorption, and that's the process of how a drug is taken into the body. And there's a lot of routes. There's oral, otic, buccal, intravenous, intramuscular, subcutaneous, inhaled, nebulized, intrathecal, rectal, vaginal, ocular, and transdermal. So there's a lot of ways that we can get drugs into the body. Absorption affects the speed and the concentration of a drug's arrival at its target location of effect. The distribution is the process of how the drug moves from the site of absorption to the other areas of the body, if it's meant to be distributed, because not all drugs are meant to be distributed. Some of them do stay local. A drug might get into the bloodstream directly, for example, by intravenous injection, and that's a really quick one. Once you've gone and injected a drug IV, it's pretty instantaneous. So there's no real takebacks on an IV drug. Or by absorption, for example, from the GI tract, the gastrointestinal tract, if the drug has been taken orally. It most often occurs via the bloodstream, and the drug is passed into the body tissues and the organs. Metabolism is the next part, and the metabolism is the process by which the body breaks down the compounds into metabolites. These metabolites themselves can also be pharmacologically active. That's pretty important. Metabolism occurs primarily in the liver. And the liver is such an important organ in the body. The liver, I'm a former organ transplant nurse, liver, kidney, pancreas transplant. The liver performs approximately 400 functions, and you really want to keep your liver healthy. And we run into problems with metabolism when people have impaired liver function. And finally, you have excretion, and that's how the compounds are removed. And the kidney is the primary organ of excretion via the urine, but it can also occur via the lungs in gases or feces. And true story, when you lose weight, apropos of nothing, but when you lose weight, you're mostly breathing out the weight. So let's say you lose about 22 pounds of fat, about 18 pounds roughly is excreted via carbon dioxide or when you're exhaling. And the other 3-ish to 4 pounds is usually through sweat and urine. So here's a real quick overview for you before we move on. So absorption, once again, is a compound's ability to pass through barriers such as the intestinal lining, the nasal lining, the lungs, or skin. So when drug manufacturers are coming and creating a new compound, absorption is a key. How can we get it in there? And does it need to be time released? And this is a really big thing. Distribution is next. That's how that compound is distributed throughout the body. Metabolism is how it's broken down. And finally, excretion is how it's removed. This is a big thing for me, bioindividuality. Each human being is a biochemical individual. This means that your experience will be unique to you. Your body may not process drugs in the same way as other people's bodies. And as my students, when I was training them in facilitation know, and all of my patients know, I'm very, very big on this because I don't really care what's happening to the person next to you. If you're having certain symptoms, I'm going to go ahead and listen to those symptoms. It doesn't matter if the person next to you is not. And that's because your body is unique to you, and we're going to treat it like that. Okay, next section, after that little brief overview there, are chemical changes. So one of the really important things to understand with psilocybin and with some other drugs as well, if you are using cannabis orally, this also applies. First pass metabolism. First pass metabolism is the process by which the concentration of a drug is greatly reduced after metabolism, thus lowering its amount before it reaches the systemic circulation. This mainly occurs in the liver, and this process reduces the bioavailability of a drug. So with psilocybin first pass, you take it orally, of course, and it's rapidly absorbed from the GI tract, and it goes extensive first pass metabolism in the liver with about a loss of 50% at that point. This is also another key point. At this point, the liver removes the phosphate group, which would otherwise prevent it from entering the brain. Psilocin easily crosses the blood-brain barrier. And so often scientists and manufacturers are figuring out how to do that. And this drug already does it pretty easily. Bioavailability describes the percentage of a drug to reach systemic circulation following non-intravenous administration. So the estimated bioavailability of psilocybin is roughly 52.7%. Roughly, this is plus or minus 20, which of course, as you probably already know, is a wide latitude, but so much of this depends on the actual fruit that you're consuming. And the half-life is only 2 to 4 hours. So just want to stop here because I get asked this a lot. Can I get drug tested for this? This is a water-soluble molecule, and it's pretty much out of your system in about 24 hours. I'm not aware of a test that employers can use to detect psilocybin in the body. The onset of action after it's consumed is about 30 minutes. And the entire experience, depending on dosing, of course, is anywhere from about 4 to 8 hours. And I'd say about 5 is average. 2/3 of excretion occurs in those first 3 hours. So don't be surprised if you need to urinate a little bit more. And it is undetectable in urine after 24 hours. So psilocybin is what we call a prodrug, and a prodrug is a precursor of a drug. It's a drug which must undergo a chemical conversion by metabolic processes in order to become an active pharmacologic agent. It's converted to, so psilocybin is converted to something called psilocin in the liver. Now, I'm going to use these interchangeably. Understand that when I'm using psilocybin, I'm also referring to the active form of psilocin, all right? And approximately 10% of all marketed drugs worldwide can be considered prodrugs. So it's not super unique. And here is this rapid dephosphorylation. Psilocin in the brain. Psilocin binds to and stimulates 5-HT2A receptors, which are found in multiple areas of the brain. These receptors are found predominantly in levels 1, 4, and 5A of the cortex, claustrum, olfactory nuclei, and the basal ganglia. Its chemical structure is similar to that of serotonin, a neurotransmitter that regulates mood, appetite, and sleep. And it is a partial agonist. Psilocin acts as a partial agonist at almost all 5-HTR receptor sites. What is an agonist? An agonist is a drug or a substance that binds to a receptor in or on a cell, and it causes the same reaction as the substance that would normally bind at that site. So, activation of these receptors leads to alterations in neuronal signaling and neurotransmitter release. The effects of psilocin on the 5-HT2A receptors and also the 5-HT2C are responsible for the psychoactive properties. These properties include changes in perception and time, visual patterns, emotional lability, euphoria, and mystical or spiritual experiences. Psilocybin's molecular effects include changes in gene expression, particularly of genes involved in neuroplasticity and neuronal growth. And I am a neurofeedback practitioner. I'm always working with my clients to promote that neuroplasticity. Neuroplasticity is that ability to weather changes in life, weather stressors. And I'll talk about that a little bit more later. So this article I just found this week, and so I created a slide for it. It came out of the American Journal of Endocannabinoid Medicine on the 11th of this month. Psilocybin, with a notable clinical safety record, raises levels of brain growth factor, BDNF, which is brain-derived neurotrophic factor. It encourages growth of new dendritic spines. It induces neuroplasticity, and it increases synaptogenesis in the hippocampus and prefrontal cortex. These brain regions are involved in learning, memory, and emotional regulation, and are often impaired in depression and PTSD. Very important to note that when you have months or years of depression and PTSD, that you actually start to struggle with things like memory, obviously regulating your emotions. The ability of classic psychedelics to influence the microbiome and the gut-brain axis, a central source of serotonin, may also underlie their help for these disorders. Okay, so a key thing is, and I know a lot of people talk to me about this, and this in part is why I decided to start a consulting firm, are these drug-drug interactions, because I'm going to stop for a second. In Oregon, we are an adult use state. Psilocybin can be used for therapeutic purposes, but there's only 3 points of entry in this state. There's the manufacturing end. Those are the people who are growing the mushrooms. There are the service centers. That's where the mushrooms are being purchased and consumed and where the journeys are taking place. And then there are the psilocybin facilitators. Those are the people who need to be with the clients, who do all of the state paperwork, get them ready, and stay with them through their journey. In other words, more like guides. Okay. And when I was training my facilitators, I reminded them that, your average American is on at least 1 or 2 pharmaceutical meds, and knowing drug-drug interactions is important. Although, facilitators do not need to be medical professionals. So a lack of understanding of the risks of drug interactions with psilocybin can result in serious health consequences. It is essential to educate the public and healthcare professionals on the potential dangers of using psilocybin in combination with prescribed medications. And this is where Jason, Lisa, and I all share that same vision of consuming psilocybin safely. Psilocybin is a potent substance that can interact with various prescription drugs in unexpected ways, and understanding these interactions can help to prevent dangerous adverse effects and ensure safe and effective medication use. Approximately 16 million Americans have taken antidepressants for at least 5 years. It's important to recognize that clients using antidepressants may experience psilocybin in a chemically different way. I have included a link, and I'm going to stop for a second so you can either screenshot this or write this down or use your cell phone for a second. This video on YouTube is an interview with Dr. Erica Zelfand. She is a local Portland physician. This video is excellent. She does such justice to this topic. This is a video that I would share with my students, and it's called Psilocybin and Antidepressants, What Patients Need to Know. You can't, I don't know that you can directly find it on YouTube if you Google her name, because someone else interviewed her, but it's about an hour-long lecture, and she just does a great job with that. So these SSRIs, or selective serotonin reuptake inhibitors. So these are the antidepressants that if people are on antidepressants, this was the next wave. So these are the things like Lexapro, Prozac, Zoloft, etc. SSRIs increase the levels of serotonin in the brain by blocking the reuptake of serotonin into neurons. By blocking the reuptake transporter, SSRIs increase serotonin levels in the synaptic cleft, thus enhancing neurotransmission. This increased serotonin availability is thought to alleviate symptoms of depression and anxiety. So really, this is how, if you don't have an understanding of how SSRIs work, they're not, sometimes people will use the analogy of like, well, I need to take an SSRI in the way that a diabetic needs to take insulin. And it's really not this, it's not a great analogy. It's not a one-to-one in that way, because what SSRIs are doing is they're just increasing your own supply. They're not delivering serotonin molecules to you. Chronic SSRI use downregulates these 5-HT receptors, and this has the effect, this downregulation then has this effect of reducing the sensitivity of receptors as well as decreasing the number of receptors. So we can talk a little bit about that in dosing, and Dr. Zelfand talks about this in her video too, but the general recommendation when we're talking about dosing for patients that are on SSRIs, if they're found to be safe to consume, is to look at, 1.5, maybe 2 times the dose of someone who's not on SSRIs. They need more medicine to kind of overcome that. Otherwise, they're just not going to have the journey that they're expecting. The acute subjective psychedelic effects of psilocybin and of other serotonergic, there we go, drugs, LSD, are diminished by use of antidepressant drugs in the weeks or months prior. Also want to pause for a second. I never make the recommendation for someone to abruptly stop taking SSRIs in preparation for a psilocybin journey. Please don't do that. Discontinuation syndrome is real. It should take you months to discontinue an SSRI. And abrupt stopping that is not in your best interest, nor is it necessary to do. Okay, so let's talk about psilocybin versus these SSRIs. So psilocybin is different from SSRIs in several ways, as evidenced by the following. First of all, that MOA, that mechanism of action. Psilocybin works by binding to serotonin receptors in the brain, where SSRIs work by blocking the reuptake of serotonin. Dosing, psilocybin is typically administered in a single dose, and we're talking more macro doses, not microdosing here. Whereas SSRIs are taken daily for an extended period of time. Treatment-resistant depression, psilocybin has been shown to be effective in treating medication-resistant depression, whereas SSRIs may not work for everyone. You know, we all know that there are side effects from taking SSRIs. Sometimes the body acclimates to that and people just have to overcome the hump, but not everybody can take the SSRIs because of side effects. Either the side effects are too severe or they're just too undesirable for them. The time frame, psilocybin has been shown to have a short-term antidepressant effect with improvements seen after just one dose. SSRIs may take several weeks or even months to take effect. So if you're also interested, there are videos on YouTube. There's one in particular, it's a British group. They put people on journeys and filmed, and the improvements, these people were, they had all, this isn't a clinical term, but pooped out on their antidepressants. They had taken so many antidepressants and they were kind of at the end, and they didn't have so many more drugs that they could be taking. And they got put on psilocybin, and the effects were really, really kind of miraculous to look at, and what that did for their treatment-resistant depression. Let's see. And time frame, psilocybin has that short-term effect. Improvements are seen after that one dose. SSRI, several weeks, several months. Secondary outcomes, in some studies, psilocybin has been shown to have secondary outcomes that favor it over SSRIs, such as increased emotional connection and decreased anxiety. Some of my patients over the years have complained about, okay, they're not as depressed or they're not as anxious after taking an SSRI, but now they feel flat and they have a flat affect. They feel apathetic about things. And that doesn't seem to be the case for my clients that have used psilocybin. So overall, while psilocybin and SSRIs both have antidepressant effects, they differ in their mechanism of action, their dosages, treatment-resistant depression, timeframes, and secondary outcomes. Psilocin also interacts with other targets, such as subtypes of dopamine, histamine, and adrenergic receptors. The role of these targets with the drug effects are unclear at this time. And, you know, this is the same issue that we have with cannabis medicine. I wrote so many papers on this in grad school. They always started along the lines, well, due to the dearth of, you know, reputable studies. And remember that this is a Schedule I drug. And as such, it's extremely difficult in the United States to do research on Schedule I drugs. As some of you already know, the government had done really good research over the years on LSD before that was taken out. LSD showed a lot of promise, and hopefully psilocybin can get descheduled or rescheduled at some point from Schedule I so that some proper research could take place. It's a circular thing because the government says, we're not going to deschedule or reschedule this drug because we don't have the studies, but the studies can't be done until it's descheduled or rescheduled. So we get caught in this endless loop, bureaucratic loop. So in our state, there is one contraindication, and that is lithium. So if a client comes into a service center and they have taken lithium within the past 30 days, they cannot go, they cannot go on a psilocybin journey. So that is the one that facilitators have to say, nope, sorry. Using caution. Caution should be exercised with clients who have a significant cardiac history, including a history of MI, unstable blood pressure, or multiple cardiac meds. So I put in unstable blood pressure. If people come in on one blood pressure med and they can report that their blood pressure is, 120/60, they get it checked, they check it at home once a week, and they're stable, okay. But, if somebody comes in and, they're on 2-3 BP meds, and they're like, yeah, no, my blood pressure still is, 170/90. I'm not going to want to take them on as a client, frankly. That's a little bit too unstable for my liking because psilocybin does elevate heart rate and blood pressure. It should not be mixed. Psilocybin should not be mixed with any other psychoactive meds such as MDMA. People might use a little cannabis at the end of their journey. That's okay, but no crossfading on psilocybin, please. Stick with just that. Serotonin syndrome is really what the state of Oregon is looking at with their recommendations when they wrote their recommendations. They're trying to avoid serotonin syndrome. Serotonin syndrome is very rare. I have never seen it in my 29 years as a nurse. That obviously doesn't mean that it doesn't happen. I just haven't personally seen it, and I have worked adult mental health. But I'm more concerned typically at the bedside when people are taking 2 or 3 serotonin enhancing meds. I don't think that there's a huge risk for psilocybin and SSRIs. That being said, there is still a risk, and it would be irresponsible of me to say otherwise. Combining psilocybin with stimulants can increase the heart rate and blood pressure, which can be dangerous, which I talked about before. And then let's move into some adverse effects. Physiological effects. So the most common physiological effects seen from consuming psilocybin are increased heart rate, elevated blood pressure, temperature changes, pupil dilatation, and increased GI motility. For that reason alone, I mean, the big thing that I see typically is on the body load phase is for some people, a sense of anxiety, maybe the heart rate starts to go up a little bit, maybe get a little bit sweaty, but nausea is extremely common with psilocybin. And they say that that's because of those, we have receptors in our gut, those same receptors that are in our brain are in our gut. And we think that the beta glucans in the actual mushroom affect that. So people come up with all sorts of ways to try to avoid or minimize that. They might have a prescription med or some Tums, or they might lemon tech it, things to just start to try to find their workaround. Ginger, for instance, ginger tea can be a big thing. So your adverse effects, because they're there, anxiety or fear and paranoia may be present. And as I just said, some users may experience anxiety during the body load phase. There is a risk of psychosis, which can be seen in individuals with prolonged or high use and susceptibility. So if people have certain underlying psych diagnoses and they're not stabilized, they are not good candidates for psilocybin. Psilocybin is not considered toxic in typical doses, and there's no known lethal dose. However, it is still a Schedule I drug, and the feds say a Schedule I drug is a drug that has no current accepted medical use and a high potential for abuse. I don't agree with that for this drug. Honestly, I would probably put alcohol far, 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 far ahead of psilocybin, because alcohol has no accepted medical use, and it has, as we know, a very high potential for abuse. But that is how it is right now since the 70s. I did put this one slide in. It's pretty rare, but once again, want to educate you on all possibilities. HPPD, it's hallucinogen persisting perception disorder. This occurs in individuals with exposure to a hallucinogenic substance, and they just keep experiencing perceptual distortions. This occurrence rate is approximately 4 to 4.5%. However, this does seem to occur more with LSD than with psilocybin. Okay. Typically for somebody with HPPD, if they talk to a prescriber and they're honest about this use, the prescriber might use something like clonidine or a benzodiazepine that might help. Okay, some effects in the brain. So I didn't go into, a huge amount of what psilocybin is clinically indicated for. I'm assuming at this point that most of you have a baseline understanding around that. I am intrigued, though, by studies that are coming up, in particular with addiction use. It's rumored, I don't know if this is true, but it's rumored that Bill W., the founder of Alcoholics Anonymous, did use psilocybin to help him quit drinking. We do know that there does seem to be an effect of psilocybin on people's propensity to consume, in particular, alcohol and cigarettes. You get a bunch of facilitators around and it's not really a hard drinking crowd. It seems you just killed the desire for alcohol. So what are the effects on the brain? Well, psychedelics, they relax that rigid thinking. They can weaken entrenched psychological defenses. And as a result, traumatic and unpleasant thoughts or feelings may arise, giving the client space to address repressed thoughts and emotions. And also, as my students know, I'm all about integrating after the journey, because I always say the same thing. If you don't do integration, then you're just doing drugs. Okay. So you have to take time to integrate. Facilitators in Oregon, the state recommends, it doesn't require, but they recommend that they have a conversation with their client about integration. Thankfully, probably some of you in my audience are skilled at doing integration. For those of you who are not familiar with integration, integration is the process by which you start to take in the information that you discovered about yourself during your journey. And this can happen in days, weeks, or months after your journey. There's no real timeline for integration. And I think that the state chose to make this a recommendation rather than a requirement because of the time frame. You can't say, well, I'm going to put you on psilocybin on the 15th and on the 22nd, we're going to integrate, because the client might not be at that place where they're ready to integrate by the 22nd. But maybe the following month they are. And everybody integrates on their own time frame, just like everybody grieves on their own time frame. Neuroplasticity. If I ever get a tattoo in my life, it's probably going to be on neuroplasticity, because this is a subject that's near and dear to my heart. And this is the reason why I do this work. Neuroplasticity is the brain's ability to change throughout life. And a person who has strong neuroplasticity may be more equipped to weather life's stressors. And as I said in my lecture at PsyCon in May, as long as you're in human body, you are going to have stress. It's never going to end. It doesn't matter. Money isn't a protection against it. Good health isn't a protection. You can lay on all the beaches you want, but eventually you're going to have some stress in your life. And neuroplasticity is how well do you handle that stress? You can get elevated, your blood pressure can go up, your heart rate can go up, but how quickly does it come back down to baseline? Are you ruminating with your thoughts? Or are you able to discharge things and move on? Okay. And I think one of the things that excites me the most about this medicine is that it really can improve the brain's neuroplasticity. Okay. I could probably just do one lecture just on dosing. This is, I think, the number one question for me from both clients and facilitators. And facilitators out there, my consulting service is available to you as well. We can do 15 or 30-minute time frames to talk if you've got a particularly challenging client that you're concerned about dosing, because dosing to me is both an art and a science. Okay. When I wrote this presentation originally, it was my understanding that the state was going to be extracting psilocin and putting it in caps, and that they were they were steering away from whole fruits. But, given the fact that everything just got rolled out in January of this year, we're still learning and processing things. So I'm trying to keep up with it. I did go to a service center in Hood River called Vital Reset, and they're using whole mushrooms there. People are not really attracted to the extracts there. So, but our law says that you have to use the Psilocybe cubensis mushrooms. Okay, that is our one genus that we're using. That is typically weighed in grams. So for those of you who are familiar with this medicine already, you know that we're doing like 3.5 grams is an eighth. And that's a pretty good dose for people. But the analyte itself is measured in milligrams. The psilocybe mushrooms have shown that they can contain roughly 0.5 to 1% total psilocin. So there's a little conversion that you can do right there. Sorry about that. 3.5 grams of whole fruit is roughly equal to about 35 milligrams of an analyte. And one of my former facilitation students, Erin, asked me to mention this too. We had this conversation the other day. Macro doses should be scheduled for no more than once every 3 to 4 weeks. Clients are not benefiting from doing this back to back. The body habituates to psilocybin very quickly, and they should not be journeying like 2 times a week, 3 times a week, or just every week. You really should maybe once a month. And I know that a lot of people are coming to this state as medical tourists and they want to get their bang for their buck, but they're just, in my opinion, wasting their money if they're trying to get 2 journeys in while they're here. Another one of my students, former students, Marlon, made this chart, and this was illustrating the amount of psilocybin analyte that people could use, the duration of the sessions, because we do have to have facilitator to client ratios if it's a group setting, group administration session. And I want you to bring your eyes down to the bottom of the screen. And typically, most clients in a service center are going on that level 4 to level 5, somewhere around there. So they want those visuals, which visuals are the first indication typically that you're impaired, that the medication is on board, either closed-eyed, open-eyed, or both. And so most people are really going for that level 4, level 5. Level 6 is what we call the heroic journey. That's when you're going north of that 8th. You're nudging into 4 grams, 5 grams, 6 grams. And that's definitely not for beginners. You do not want to go that high on your first journey. Microdosing. This is a topic that microdosing is really what got me into this arena originally. Full disclosure, I started by microdosing some years ago, and it helped me weather some of the stressors that were happening in my life at that time. And I am a science girly. Unfortunately, the science right now isn't super supportive of microdosing, but these are the types of studies that are anecdotal. It's not like people are in, it's not like a double-blind phase 3. So I'm hoping that the research will back this up. I'm respecting that the science doesn't quite support the premise of not all science studies are supporting microdosing right now. However, microdosing anecdotally works. It works for myself. It works for a lot of people that I know. And it is the practice of taking scheduled doses of a small amount of a psychedelic to produce subperceptual results. So a microdose of psilocin analyte is about 1 to 5 milligrams, and the average microdose of psilocybin is 0.15 grams. That's my recommendation, by the way. If a person starts at 0.15 grams, they have capacity to titrate up or titrate down. I personally don't recommend going above 0.2 of a gram. But you can titrate down to that 1/10 or even less if you need to. This is also a place where I'll pause and talk about Fadiman and Stamets, 2 gentlemen who have a significant presence in this arena. I love both of their work. My feeling about microdosing is I prefer an every other day microdose and then take a tolerance break for a week after 6 weeks and then start again. Fadiman is 1 day on, 2 days off, which in my experience doesn't produce the same effects. That second day, people kind of poop out a little bit. And Stamets is really big on what he calls the Stamets stack, which includes lion's mane and vitamin B3/niacin. And I love lion's mane. If you want to take lion's mane, please do. It's a great supplement. I don't see the need, though, for the niacin. And for my clients who are north of age 40, especially my women who are north of age 40, they don't enjoy that niacin flush. And yes, you can get non-flushing niacin. I just don't see the point. And I'm a person that says, take minimally what you need to take in. So I don't know that you need to stack in that way. Once again, this is my opinion, and both gentlemen have great bodies of work. Okay, and then this is pretty much it. I just put a little cartoon on there at the end because I think that a lot of us that are in the field, we have our our public face and then our psilocybin face. As my friend Heidi texted me today, she says, I know too many Anns in my life. So when I'm talking about you to my boyfriend, I refer to you as Mushroom Ann. So there you go. I'm Mushroom Ann. So I'd like to open it up for questions now. And we'll go. We're good on time. It's 6:53.
Yeah, thank you, Anne. And while everyone's formulating your questions, feel free to, at this point, you can either ask the questions in the chat, and Lisa and I would be happy to present them to Anne, or you can ask them personally. Do want to respect everybody that we did say, you know, this will go till 7, and we are fine with continuing on for additional time if you need to. If you can stay even after we stop the recording, we're happy to, you know, answer some additional questions. Real quick, just on the Psilocybin Assisted Therapies Association, our mission is to promote the advancement of psilocybin assisted therapy. Our premise is on educate, empower, and heal. We want to provide educational materials so that everybody can feel empowered on their own process and progress of going forward, however they may choose. We have some great resources on our website, including an in-depth guidebook all around psilocybin-assisted therapy. This is a free download. Feel free to get that off of our website. We are also available for questions. If you have something and you want to learn a little bit more about any of the processes, I'll include my email address in there. Feel free to reach out, and I'm happy to discuss any of this and provide details in the future.